can actually take home for this. So these are my disclosures. How much correction? And there are a variety of different factors. There's not one case fits all as far as things. We look at things about the symptoms and the alignment, and the age and the bone quality, and a variety of other different factors that factor into how much correction we want to be thinking about. And we also want to think about the risks. The fact is, if we either overdo it or underdo it, there are true risks that can develop, and these can be, people having pain or poor function. They can have complications, as Sig had mentioned, particularly mechanical complications. So I sort of start off with this case. This is a case that was sent to me, 78-year-old, multiple medical problems, history of breast cancer, early dementia, congestive heart failure, but it's coming in, just dragged in with horrific, unremitting leg pain. And she's got this scoliosis, she's got osteoporosis. And what do you do for this? This is her MRI scan, and what we ended up doing is doing several transforaminal epidural steroid injections at L3-4 and L4-5 that gave her great relief, but it only lasted for a couple of weeks. So even though I generally do big deformity surgeries, I sent this to one of my partners who does awake endoscopic procedures, and he did an endoscopic foraminal decompression at L3-4 and L4-5. She's about 6 months out now and is about 80% improved as far as her symptoms are concerned. And the question is this in our thing? Is this something we should be part of our armamentarium? And the reality is, as Cliff Crutcher knows, at Duke, we have got now several endoscopic surgeons who are doing this on deformity cases. And this nice article looked at the patients who ended up having either endoscopic decompression or limited decompression. And what they found was that the number of people that ended up progressing in the time period of 2 years that they followed them was relatively low. With endoscopic decompression, the curve progressed about 2 degrees over 2 years. But the one thing to do, the red arrow there, is almost every one of these patients was very well sagittally aligned. So what you can do with somebody who's got foraminal stenosis and scoliosis and who is well sagittally aligned may be different than the people who are poorly sagittally aligned. So this whole process, and again, one of the things is I get complaints, oh my goodness, every time I go to the SRS meeting or a NAS, there's some new set of parameters that the ISSG is coming out with. Why is it you guys can't come up with some firm recommendations? I'm going to try to do that in the next couple slides. So this meeting was started by Tom Lowe, and Tom and Sig and some others did the first SRS classification. And initially, most people, the thought was that basically that adults were older children and that the King-Mo classification could be followed. And there were some minor modifications, but basically that was what was originally thought. Hey, we should treat this like we treat idiopathic scoliosis. And the fact is it led to a number of disastrous results, and several of the cases that we're talking about are flat back ones later on, and that's sort of a result. And there was a gradual realization that, that a big component of degenerative deformity and degenerative conditions was disc space collapse and the loss of lumbar lordosis. And this led, to these spinopelvic parameters that got to be measured, and it led eventually to the development of the SRS Schwab classification system, which took into account, the mismatch between lumbar lordosis and pelvic incidence, and the pelvic tilt as a compensatory mechanism in the sagittal vertical axis. And suddenly it found that way more than any of the coronal parameters, these were the major drivers as far as symptoms were concerned. So this led these general alignment objectives, and the fact is, particularly for older patients, this probably resulted in over-treatment and resulted in this huge increase in proximal junctional kyphosis that ended up by developing by over-treating patients who couldn't tolerate that. And this is showed for people, particularly middle-aged patients, if you aggressively treat them, their improvement in symptoms is going to be absolutely dramatic. And this is an example of a patient of mine, ODI of almost 70, severely sagittally malaligned, and I did this 3-column osteotomy, and the patient is ODI is 11, just dramatically better with this. So one of the things which is increasingly recognized is the importance of the lumbar lordosis, particularly in the distal spine, and I'm going to emphasize this in a couple things. And so what's happening is the lordosis between between L4 and S1 should be about 2/3 of the lordosis. And what's happening is that when we've looked at a variety of different parameters, and again, this has been shown for even simple cases, and this was some work that was done for 1 and 2 level lumbar fusions, and what they found that those patients who had a significant spinopelvic mismatch upon the completion of their simple surgeries had a very, very high rate of adjacent segment disease and reoperation. Adam Cantor, who's in the room, this is from his group, and they looked again at those patients with simple lumbar surgeries. And what they found was if you had significant spinopelvic mismatch, particularly in the distal lumbar spine, that you had almost 100% chance of needing a revision spine surgery down the road. And Adam can if I've misquoted him. So what's happening is this is another study, again, looking at adjacent segment disease, and what they found was the single biggest parameter that led or not led to it was the proportion of lordosis between L4 and S1. Now, how do we achieve lordosis? And this is looking at bigger cases, and this is some work, again, through the ISSG, and we looked at the options of either doing A-lifts between L4 and S1, doing L4 or L5 pedicle subtraction osteotomies, or doing a T-lift. And what they found was for most surgeons that if you did an A-lift at L4 to S1, you were able to really achieve great alignment with the lowest complication rates to do it. The T-lifts had a little bit of undercorrection. The L4 and L5 PSOs had a very high complication rate, and so the A-lift was felt to be the sweet spot when you can do it appropriately to treat these different conditions. Now, what's happening is, as we learn stuff, we learn that there's always exceptions to the rule. And one of the things which has been shown is the lumbar lordosis, as we know, varies with the pelvic incidence. So what is true for 80 or 90% of the people with a normal lumbar lordosis, 50 degrees plus or minus 15, may not be true at the very extremes. Those people with the very low PIs or those people with the very high PIs. And with this is some work that's been done looking at what the normal anatomic alignment is for the majority of patients. And what happened is this change related to pelvic incidence differences has led to this Rousselet classification where the ideal lumbar lordosis lies becomes higher as your pelvic incidence essentially increases. So particularly for those people with low pelvic incidences and normal pelvic incidences, the focus of getting the majority of the lordosis between L4 and S1 becomes particularly important. And this is some work looking at this, and this is some work through the ISSG, all finding the same thing, that if we go and we get good lordosis in the distal lumbar spine, that our complication rates markedly reduce. And how we do it is a little bit user dependent. What I do is maybe different than what Bob does or what Reg Hay does or Sig does, as far as how to treat it. But increasingly it's been showing that this distal lumbar lordosis is really, really important. And this proportionality of lordosis is the underpinning of the GAP score that people hear about to do these different things. And again, more studies showing how important the distal lumbar lordosis is. And one of the important things for this, and this is a review of all the different papers looking at calculations of what the ideal distal lumbar lordosis is. And what this result of this meta-analysis is it basically for everybody, no matter what your pelvic incidence is, with rare exception, your distal lumbar lordosis should be somewhere between 35 and 40 degrees. And if you achieve that, you are going to get a consistently good result with a low incidence of adjacent segment disease. And this is, again, showing complications. This is more ISSG work. Again, emphasizing the importance of the distal lumbar lordosis. Now, one of the things which has gone into place is probably the amount of lordosis that we need to achieve as you get older becomes a bit less. People are sort of have less demands on their spine. They can tolerate a little bit of spinal pelvic mismatch. And as you get older, the risk of mechanical complications become higher. And this age-adjusted criteria goes and shows you should soften your correction goals in general for older patients. Now, basically, what this shows is that if you slightly undercorrect a patient, the consequences, particularly for older patients, is relatively low. If you overcorrect them, the complication rates just blow through the roof, and you really want to avoid overcorrection. So what the point of this is, you don't want to overdo it in your elderly patients. And by going and following this slight degree of softening of correction goals in elderly patients has been shown to reduce mechanical complications, particularly PJK. Now, we have the pleasure of having Greg Mundis in there, and I think that this is a revolutionary paper. It just came out in December in Journal of Bone and Joint Surgery. And this is looking at hundreds of patients through the ISSG. And what happens is they're looking at this T4 and L1 hip axis. And what has been happening is that if you can go and align the patients using these parameters, and this is an article that is worth reading and maybe Greg commenting on it, but what happened is through the ISSG work, and you can see, if things were very well aligned, there were no failures using these parameters, or almost no failures. That's on this area of the slide. If you look here, and if they are mismatched, okay, and this is something that is correctable intraoperatively, and this is particularly for bigger cases. If you're mismatched, you have got a very high risk of having a poor outcome with surgery. And I think it's something that, this is an article that is definitely worth reading. So the bottom line is, how much do you need to achieve? You know, the fact is that if you're younger, you need to achieve more. I think it's really important that you get about 35 degrees of lumbar lordosis between L4 and S1, and almost all the degenerative cases we're doing, whether it's a simple one or it's a complicated one, that should be a goal. Whether that goal is achieved with an A-lift or a T-lift or, you know, or a lateral procedure, that's up to your individual skill sets, but it's important to do this. And if you do this, I think you'll get the right balance between risks and benefit. Thank you.